It's indeed an honor to be here today, and just a second, it's not showing, please. One sec. Wait. Respected chairpersons and my dear friends, the topic, and thank you very much for allowing me to speak before my time. The topic on which I'm going to talk today is, just a second, where is it? Refractive surprises, tips and tricks of management. There's a bit of audio. Can you please allow the audio to play? Just keep it low. So I have no financial interest in anything that I'm going to talk about today. Now previously it was to restore good vision. That was all for cataract surgery when we were doing cataract surgery. That's removing the obstruction that was there with or without glasses to see well. But now we need multitasking, looking at all distances, intermediate, near, or for distance. The lifestyle IOLs are there. People need to see at a time at all distances, and the dilemmas are that there are Google teachers, people know about the newer IOLs, they ask for it. So we need to spare more time with them, choose the best IOL that suits them. And even after a good surgery, we may have refractive outcomes which are surprising, either for the clarity of vision, distance or near, or due to the other reasons like dry eye, PCO, macular pathology. I'll be discussing some cases about like this. Case 1, which was a very dissatisfied patient which wanted IOL exchange. This was because he had minus 2.5 residual astigmatism, and when we looked into the pre-op biometry, found he already had pre-op astigmatism of minus 2.25 and 2.5 in either eye, left eye, already had. So now my task was to deconvince him for IOL exchange, which is never a very good procedure. Convince him and send him for refractive surgery in the left eye, or do a right eye surgery. I did a right eye surgery. He got a Plano 6.9 with a toric IOL plus 3 with add, and left eye I could convince him for a spec power, and we sent to the retina colleague. But not always are we so happy, especially with multifocal surprises, dysphotopsia. So the options, what are they? Laser, IOL exchange, or a add-on IOL. Now IOL exchange, where we can't do anything else, I think there we choose for it. If for example there is a opacified IOL and the patient's vision drops, or there is some other reason. But this is a very tricky technique, because if it is very well adherent, we may lose the PC. So it's better to lift the IOL from the junction of the optic haptic. If you can move it, slowly dial one at a time from the out of the bag, and then after forming a good AC, you can take out one of the haptics from the main wound and then cut the IOL either through and through, full thickness, totally or halfway, and then slowly dial it out to keep the wound, slightly stretching the wound, not enlarging it. Once you dial on one side, and then you can rotate it on the other side and take it out. Thanks to some of my mentors, this procedure was taught by them, and then you get a good AC depth. And if you are lucky enough and have a good bag, you can reinsert the same type of IOL. Just look, we have these complications, the iris chafing, or sometimes trauma to other parts. Now biometry in these cases are usually done by Barrett, IOL master. You can also do with ultrasound. You can use the immersion method to find the calculation. The next method is the laser, PRK or LASIK. Photorefractive procedures are very good when you have higher order aberrations, but keep an eye for OSD, ocular surface disorders. They are very effective for elimination of post-operative surprises, and especially with femto laser correction, LASIK, it is much better, because this is a very good procedure and best suited for myopic surprises, where we actually create a flap with a hinge and with the tracker system. This is the Zeiss refractive suit. You can actually femto out the flap and use excimer laser to do the ablation and do as much correction as you feed in the machine. And the procedure is very neat and clean, and the patient usually recovers very well. Of course, you have to keep an eye over the ocular surface, as I said, and it is very happy procedure. Sometimes you have some special scenario like this where you have very high myopics with IOLs which have to be tailor-made, a myopic IOL, and you never know what you're exactly inserting, what you're actually going to do, but then you have to do. And you have huge refractive surprises. This was a hyperopic surprise. So here in this case, the patient was very highly myopic. So we did not want this patient to end up in hypermetropia, and I had a choice of IOL exchange or piggyback. Piggyback IOLs are not easily available, neither are these sulcus IOLs. Piggyback IOL, you actually have to put a hydrophilic over silicon or silicon over hydrophobic. This was a add-on, but sulcus fixated IOL and more like a phakic IOL. It only that it was inserted in a eye which already had a PC IOL, and the design of the lens is different from that of a phakic IOL. But if you have a good AC depth and well done, well-centered PC IOL, this was in topical, by the way. It's better to do it. I learned with time that it's better to do it with injection. I mean peribulbar, it stabilizes and reduces less pain. You have to have a very stable anterior chamber, good viscoelastics guiding your lens. This lens, tumbling of this lens is really difficult. So it's better to guide the lens, go slow, look out for the proper notch if it is well placed, tucking the IOL, and be very careful not to put it in the bag, because this is for the sulcus, and sometimes you may end up while tucking, it's very flexible, and it goes in the bag itself, so then it's a big problem again. It's very difficult to take it out because the bag cannot tolerate 2 IOLs at a time, and especially a fibrous bag. This is fibrous because I waited for a pretty long time to find out the change of refractive error, and until it's stabilized we did not do the case. It's better to do a peripheral alectomy since you have 2 IOLs, and do a thorough AC wash in between the lenses. Their viscoelastics, they create problem. And this patient ended up quite well with a good result, AC depth and good vision. So these are the take-home messages. Customize each case and choose for the need of the patient. Spend more chair time when you have refractive surprises. Choose the correct procedure. Choose the best method, judging the pros and cons. And careful refractive estimation. Please wait for the refractive error to stabilize the spherical equivalent. Look out for factors like OSD, PCO, astigmatism, gutta. Counseling is very important. Sometimes simple counseling with little bit of here and there is always good, and surprises always help you learn. Thank you for patient hearing.
Sudipta, your IOL exchange case had opaque IOL, isn't it?
Yeah, this case was opaque IOL, but this is for the sake of mentioning the IOL exchange. But usually we do in clear lenses also if required.
Very nice presentation.
Thank you so much.